to the 5 doctors for being here and hopefully be able to answer some of the questions that we've got. So Katie is going to ask you some of the questions that come in and we'll take it from there.
So these are some of the questions that have been submitted. So first one, I'm interested in receiving an update on patients with double mutations. I would like to know how many patients that you are aware of with second mutations of which second mutations are frequently observed and what implications these mutations might have.
So, yeah, we just discussed that with one of the participants. We have very few of them. Recently, in our cohort, we have studied 150 patients, about 100 or 200, I don't remember exactly, who had different types of mosaics. I think only half of them had PROS. And we found only 3 patients with double mosaic somatic variants. Only 1 patient had PROS with the PIK3CA variant, and she also had a second mutation, second variant in GNAQ, and she definitely had a widespread, extensive capillary malformation, pretty pale, and she has a darker one, a linear darker one, which means that she definitely has a second event which results in something on the skin. But this is the only PIK3CA patient I know with the second mutation. The others are either a GNAQ patient with a second PIK3CA mutation with lower variant allele fraction, and the other one is a patient with congenital myelocytic nevus with an NRAS mutation and also has venous malformation with the TEC variant. So there are double mutations. They are rare. They are not well known. They may have been under-recognized so far because we didn't perform panels systematically. But they exist, and they can cause different phenotypes.
So, yeah, just to add to that, they certainly happen. Of the 300 or so that we looked at, we found 3 or 4 examples of people who had PIK3CA mutations and one of these other mutations as well. Without going into all the details of that, what that means in practice is that usually there is a wider area affected by the first mutation in PIK3CA, and then you can usually see something inside that, where the second mutation arose. And if that new little area is causing extra problems, that can be treated in its own right. But and this is published as well. And I think to some extent, any time you have more cells growing, there is a greater chance of getting second mutation. So I think this will always happen. I'm just not aware that this causes any particular new thing to worry about. If anything, it might create some new opportunities to target that second area with other medicines. So it does happen, is the answer at a low rate.
We've had a couple too, so perhaps we should look at them together.
Okay, moving on to the next question. I have observed a notable occurrence of fraternal twins in our small community. I'm curious if they have also been observed, if you have also observed this phenomenon, and if they have any information regarding it. Is there a potential correlation between the prevalence of twins and the increased likelihood of having a mutation?
Not as far as I know, from my own experience.
I don't get a similar question in the US though. I mean, anecdotal again, because
we didn't see that in I think we looked at 300 or 400 patients in the UK. We didn't have that experience there. I mean, and to be clear, as I mentioned this morning, it's not that people who don't have PROS grow up with no changes in genes, no mutations. We're all absolutely full of them. And people that do genetics can track exactly where any cell in your body came from by analysing the pattern of mutations. So they are happening all the time. It's just a matter of plain bad luck that one lands in the PIK3CA gene. But no, I haven't seen any excess twins.
And that goes across mosaic disorders actually, because you see a lot of different disorders that are the same theoretical basis, so a mutation in a single cell would give you different things to pros, and there's certainly not more twins in other cohorts that we see a lot of.
Okay. Next one is, I am interested to know if there are any drug trials for children with segmental overgrowth syndrome, in this case specifically the child is age 7.
I think we've covered that over in the talks.
Moving on, the next one's quite long, so please bear with me. The latest news of the Novartis withdrawal of their marketing authorization application for Raltisa from the European Medicines Agency. We're aware of the doctors from Canvas, and they have pulled the application to make some changes, especially in the control group information, since there was more disease progression than expected among the group. They also said that after adjusting the application and the protocol that they will resubmit, we're aware that it won't affect drug trials or those using the medication for compassionate use or managed access programs. However, do you have any further information on this news or what the long-term outcomes of this could be?
No, but I think that's not completely surprising, and the EPIC-P2 trial is a big, complex international trial, and a lot of information is accumulating as the trial runs. And they're slightly adjusting the trial as it goes along as well. And so I don't think any of us have a complete oversight of the data. That's just the people up at the top of the trial who at some point will break the blinding. But I think the news that they're taking some of the learnings so far to adjust their application is not surprising to me, but others might have comments.
Don't know enough about it.
So I've heard something similar, and I think it's, as Rob said, it's not unusual for this to happen, particularly where you have a mosaic disease, where it's really hard to, as Pierre was talking about, define a standardised outcome measure. So in that trial, they collected different outcome measures. Their primary outcome measure was 20% reduction in volume. But to be approved by, unlike FDA approval in the States where a drug has to be safe, to be approved in Europe or the UK, you have to be cost effective. So they have a lot of data. I imagine they'll have to analyse it in lots of ways to show cost effectiveness, which is slightly different from approval in, say, the US, where something just has to be safe. So I don't think it's surprising, because I think mosaic disorders are very difficult to agree endpoints and objectives for. And I think it's good that they're taking time to go through the data, resubmit it. But we don't have any extra information, but I have heard something.
That was the end of the questions that I had been submitted to us. I don't know if anyone else has got any questions to ask.
So I'll ask something, I mean, it's a bit random, a bit, might be not answer, but where do you see kind of pros going or research going on? You mentioned about targeting particular like proteins. Just generally, where do you see kind of things going for pros within the medical field in months, years, decades to come?
So I think the exciting thing is there's loads of people, so Raltisa's doing amazing work, Rob's doing amazing work, there's loads of people around the world doing amazing work, and I think there's loads of different approaches. So Raltisa won't be the be-all and end-all drug. There's many people looking at, you know, mechanistic insights to how things are working. There's teams working on genetic therapies, lots of different teams with lots of different sets of expertise in different parts of the world, with lots of excellent people in the UK. So I think anything's possible. And yeah, you heard more about Raltisa's work and some of the excitement.
Yeah, I guess I don't have much to add beyond that really. And more personalised approaches, I suppose, but also from a mechanistic point of view.
But you know, I think there's lots of excitement and tension, and we touched on gene editing, so that there could be gene therapies in the future. It's perfectly possible, and new clever ways to use drugs. And it's really important to have that excitement, and all of us who do research are trying to move that way. But just to emphasise as strongly as possible, using all the things we know already really well, making sure that other doctors know about them, making sure that everybody around the country gets access to doctors. You know, that will be the biggest win by far in the short term. And that's partly about awareness, and that's everybody in this room making a noise and using social media and having a profile. It kind of shouldn't be the case, but there are a lot of diseases, and there's a lot of rare diseases out there, and So you need to be organised as a whole community of patients and doctors to put them on the map so that when a grant application arrives to try to do research, people have heard of it, and there's websites they can point to, and there can be support from patient groups as well. So there's a kind of lobbying and political element to making things better across the country. Because I suppose everybody here in this room is quite well connected in some ways already, but there's an awful lot of people who aren't here who would benefit from being here and probably are suffering the same experiences of being on their own with doctors that don't understand about this. So I think lots of exciting stuff for the future, but really important to make stuff better now as well.
And maybe to add to Rob's point, I think a similar message applies also in research in terms of breaking silos down, because there's a lot of stuff that's happening in the cancer world, so I'm partly straddling sort of both fields. And a lot of that technological advance, if you like, and knowledge advance could easily be transferred across to a sort of rare disease like PROS, but there's just not enough cross-talk. I'm just thinking even something as simple as therapies that target certain cells selectively. You know, you can use approaches to really get a drug into a particular cell, right? So that's, a lot of that is advancing in cancer. I see long term, we would need to be targeting cells much more specifically in terms of only hitting the thing that needs to be hit as opposed to everything else. So, you know, again, a lot of that is advancing in other fields, and potentially one could learn from these other fields as well.
Can I make a comment? We've talked a lot about new drugs, fancy drugs, exciting new things, but there's quite a lot available that we haven't talked about. There's compression, there's sclerotherapy, there's cauterization, there's going to be topical sirolimus, there's anticoagulants, there's antibiotics if you're getting infection. There's so much management that we need to optimize that we already have, and I think it's important to not lose track of what's available at the present time, rather than waiting hopefully for this drug or other drugs that actually are not going to ever be a miracle cure. They're just going to moderate the problems, I think. That's yeah.
I think the difficulty people are finding, well, I don't know if it's that as well, but just after diagnosis, just feeling as if you've not done everything, so then you're trying to get a second, well, not a second opinion, but just to make sure you can do everything that you can for them. But it's like fighting a wall to try and get somebody else to review your child, unless, which is quite difficult to go against the medical professions that are looking after them, if that makes sense.
No, I think it makes perfect sense, and I think there's a lot that's wonderful about the medical profession, and there are some things in the modern age which are incredibly frustrating. I mean, first of all, everybody's quite overworked, and there are still some of those old-fashioned sort of barriers, and the way a person gets from one doctor to another is the first doctor knowing somebody and writing a letter to the second doctor, and that's incredibly frustrating how slow that, and that's the value of social media and patient support and advocacy groups, and there's a real art to respectfully making a real nuisance of yourself if you're not getting what you want. I'd encourage that to certainly, these days as doctors, we're there to give you the best advice we can, together with you, and then you decide what's the best thing for you based on what we say. And so I think you're right, there'll still be pockets of doctor being the chief that tell you what to do, but that's not the way it should be. So make a nuisance for yourself. Don't be rude if you don't need to, but if you do need to be rude, don't accept that, I think is the answer. And look around on the internet, connect with Mandy, the people you've met here. Those barriers can always be overcome, so don't accept that.
Because I think that's the thing, sometimes you're not saying, oh, are you sure that's right? All you're saying is there anything else I could do? Like, you're not trying to say, oh, should we be doing something different?
And you shouldn't feel that asking the question, is there somebody else I can see, or can we do anything different? Yeah. That shouldn't be taken to be a challenge. There's so much that's tricky, and a lot of stuff that's a little bit unknown about these conditions as well. I think that's a perfectly reasonable question to ask.
And there are a number of specialist clinics, as you can see, and we accept patients nationally, and I think maybe on your website we could through our rare diseases network, perhaps they'd make a list of those specialist clinics so that their doctors can access them.
I think one of the frustrating things is I think you can't always advertise medical services.
Oh, right.
Fallen foul of this.
Okay.
So check the rules first.
But you can already see.
Hints were saying that the RDCN status means you can advertise.
Okay.
So that's it. That's what it gives you. I think.
Because it's
That's
been approved and we've been through the process to be
Yeah.
accepted.
There are funny rules about these things, yes.
Yeah.
Make sure we stick with those rules.
Because the centres are already listed on the RDCN.
But also make sure to talk to some of these other organizations in other countries. I think Clove Syndrome community in the US is a fantastic community to engage with as well if you haven't come across them, because they're just, it's the power of numbers, there's just more of them there. And there'll be more exchanges, experiences to be shared, and also just knowledge exchange across the communities. There's also several, like NCAP and is the one in Spain, MCM. There's one in Spain that's something related to MCAP, but...
I think there is a lot to be learned. I mean, America is a very, very different place from the healthcare point of view to the UK. But patients sort of have a lot more power, partly because they have to in the US. And so a lot of these patient groups and patient advocacy groups, you know, pretty muscular in raising funding and setting the agenda. And maybe there's a little bit less need to do that in this country, but the same token, you know, they won't be doing what they're told by doctors in the most respectful way. But as Raltisa said, they also have just bigger numbers as well. So I think learning by connecting with those groups as well. I mean, what's the situation for the balance between patients and doctors in France, Pierre?
We have more doctors. We have rare disease networks. I think it has really improved the way, and also it's, access to drugs is much easier in France.
But in terms of the sort of balance of power between patients needing to be vocal and getting what they want versus trusting doctors to do it all for them, how does that work? Is it still quite a respectful doing what the doctor says?
No, of course not. No, but it's very different from here. I find it quite different from here. Yesterday I was at the Paris meeting of our, the annual meeting of our network on rare skin diseases, and I think that patient support groups are very active, but they don't really know how to work. It's a bit like you said. There are things that are difficult for them. They don't always know where to get the money, where to find things. And I think an important point is that the successful support groups, patient groups, are the ones who are in connection with drug companies, of course, and who know how to speak to them. So yeah, so I think it's a bit different. I think that, for instance, the pro support group in France is not very active, surprisingly. Some others are. Some disappear. Recently, I wrote guidelines for the Sturge-Weber syndrome in France, and the patient support group was supposed to be part of the work, disappeared. There was nobody left. So it's not well organized.
Sounds not dissimilar to this country.
Yeah.
I mean, the other thing to say there are very powerful ways to build databases, and these days do trials using databases rather than all the work which you heard about from Professor Mansour. But if we do it as doctors and researchers, I mean, quite rightly, there's a huge amount of regulation that we have to go through to get approvals to do those things. But if you start registries among a patient group, among a patient advocacy group, you actually have much more freedom to do it in a way that benefits you. It's still best to do it in partnership with the people that might want to use it, but there's a difference in regulation, and you can be more nimble if you do it as a patient group as well.
On that note, they have just been approved to do that in the US, so Kristen is going to actually lead on that. So there's, again, potential for crosstalk. They're starting this patient registry.
And again, among all the different types of rare diseases, there are examples of different rare diseases where they've gone through this journey and set things up. So it has to start with people who've got the time and the motivation, and especially the time to do this. And if anyone was interested in doing that, we can help connect you up with people in different diseases who've done these things as well. But you know, it does take time, and we've all got finite time, and if you're in Epic V2 study, you've got very little time to spend on time, etc. So we understand that too. But,
can I ask one about the Serolinis? Is there a limit on how long you can be on that for?
No, I mean, there's very few limits for anything, and sirolimus is used for a lot of other conditions, including after people have had transplantations, for example, and then they're on it for many, many years. So there is no hard endpoint. There are some complications of medicines which only gradually appear as many, many years go by. So it's not so much that there's a limit to how long you can be on it for, but there might be some other things to think about as the years and the decades go by. And again, often in prose, I think we're going to fall off the end of what we actually know rigorously from clinical trials. So having frank conversations with doctors about pros and cons, and then making the best decision based on that is what we're going to have to do for probably quite a long time.
Yeah. How would it work when they put Margaret on it, and it was the trial, and then they took her off, and the way she dropped back to how she was, and then when they put her back on, it took such a long time for it to not get back fully as it was, but get a lot better than what she is. And then the worry is, well, if you can only have it for so long, is she going to go back down to how she was?
In a trial is very different to outside a trial. So any trial that we do has to have been strictly approved with a fixed amount of treatment, and then once that ends, you have to obey whatever the trial rules were. But if something is being used as part of looking after you in the NHS, then actually there's a lot more flexibility. And it's about doctors together with you deciding on the pros and cons, looking at how much good it's doing, being aware of any potential side effects, and just making sure that you're all happy that it's the right balance of the two. So outside the trial, things are, as long as you find doctors that are comfortable to prescribe these things and have some experience, then there's a lot more flexibility. I think that's fair.
Definitely. Unless you're getting side effects.
Yeah,
Mouth ulcers.
just pure mouth ulcers, that's about it.
That's basically it, yeah. But it stops the bleeding and the breathlessness. It is amazing what it can do.
Purely experimentally, I'll say, in the world of research, there is interest that sirolimus might make you live longer, but this is very much. So not everything is about.
We're hoping that we'll be able to access some topical sirolimus, which is particularly good for leaky blisters. So we haven't got it yet, but there's a couple of conditions in the same pathway where they're working really hard to access that. And it will be safer than sirolimus, less side effects, and it might help with certain aspects of leakage.
We use topical sirolimus at the moment in children, and it's good for, especially starting a systemic medicine in a child who has a vaccination schedule and has a developing immune system. So sometimes for targeted problems, flares, small areas of infections, it works really well.
So you prescribe that as preparation in the NHS?
Yes, so our pharmacy makes it up.
Oh, you make it special?
Yeah.
Can we have the recipe?
The access is not very good. We have to come to London for blood tests because the blood test she has in Doncaster, it just comes back as unknown. They don't know what they're looking for. So we have to come to London every month for blood tests for them to check the levels.
And honestly, that I don't know the details of which doctor. That shouldn't be necessary.
No, because it's used post-transplant for liver.
Yeah.
So that's a matter of which doctors are speaking to which doctors, I think, and that should be fixable. But you do want to have doctors
They write
involved.
it on it, what it is and where it's meant to be going, and just comes back as unknown.
That might be one of those examples of where you should make a bit of a nuisance of yourself and say, this must be possible to do better. But,
speak a bit louder.
My little one, she gets her bloods done in Aberdeen for her levels. They do take about a week to come back because they send them away to Glasgow or something. But they take them and just send them away. So that might be
They don't
worth
take
it for you.
Margaret's, but it just comes back as it comes down. They don't know what it should be or what it is.
as you say, I'm sure there are other departments in the hospital that are sending those blood tests off somewhere and getting results back. So that really should be fixable because, as we said, there's a lot of people who've had a kidney transplant or another type of transplant who take sirolimus and they get their measures, their levels measured, so I'm sure.
Usually back in the same day.
Is there any research with being passed on to hereditary? So somebody who's got PIK3CA gene passing on to their children?
I think I'm doing too much talking.
I'm the geneticist. Am I the only geneticist? Yeah, I'm the geneticist. So if you're mosaic for a mistake in PIK3CA, and supposing it hits one of your sperm or eggs, then you can imagine the baby will have it in every cell in the body. And although there are 1 or 2 case reports, a few children who are born with PIK3CA in all their cells, it's usually a much milder variant. We think very much that if they inherit the PIK3CA that causes PROS, it probably does not form a viable pregnancy. So I've never seen it affect offspring. And although they always write there's a theoretical risk, I don't think it's real at all. I think it's extremely unlikely it will affect any of your children or your siblings.
Thank you.
Any more questions at all?
Yes, maybe one. Something which hasn't been mentioned at all is surgery, I think. And our idea, what we were told so far is that we shouldn't do a surgery because it will quite quickly grow back, the overgrowth for a child. But the idea we had in our mind was always, well, as soon as we start a medicine which can stop the growth, and our child gets used to this medicine and there are not too awful side effects, surgery could be a next step. Is this something you would agree with, or do you have any further thoughts to that?
Mandy could answer
So it depends very much on the case, and actually when we see children, we'll often see them with a plastic surgeon and an orthopaedic surgeon, so the whole team, and then we'll debate the options of each treatment modality that might be available and the timing of others, and it's never a one-stop visit. It evolves as, so I see children, so it evolves as the child grows older, and we'll often use so by the time a child's 18 in the XR centre, we'll often have had a combination of treatments. So we've had radiology treatments and injections and surgery and medicine, sometimes to treat different areas. Again, it's a different disease, every child is different, but often our approach isn't one or the other, or if it's one now with the view to doing another in the future, but it really depends on the patient.
I did actually have quite a lot of operations to reduce this in my life surgery, but it's go back. Within a couple of years, it will go back. But again,
So I think again, this is one of those areas which is not going to be sorted out definitively by a trial, at least anytime soon. And I think surgery is always a very important option, and it should be a wise surgeon, depending on what the PROS-related problems are. What you want is a surgeon who has experience of the condition, a surgeon who is wise and not too keen to operate, but is happy to do the right operation at the right time. And so that's particularly important when children are growing. As to whether or not being on some medical treatment will reduce the rate of regrowth after surgery, if it's just soft tissue that's taken away, it's a sensible idea. But I don't think we have evidence about that. I haven't got experience of that. It is a sensible notion. But the other thing is, I think you're likely to have to stop the medicine immediately after surgery to make sure that healing happens well as well. So there would be a period of 2 or 3 months probably off the treatment. Others might have more experience.
There's quite a lot of data from America now, so a lot of data that's been presented but not published with big cohorts where they've looked at wound healing on sirolimus post-surgery and actually suggested that it's not any worse.
And so would you not stop it now?
So on the basis of the data that I've seen, again, that's been presented and not published, I think I would be less absolute about stopping it, and maybe I would introduce it quicker. But again, this is data that was presented by 2 different groups a couple of years ago and has not yet to make print. But I'm less anxious about it now. Professor Langus, yeah.
And in the early days of being involved in this work, sometimes you heard the worry that if you had surgery, actually the growth would come back worse afterwards. Personally, I haven't seen any examples of that, although sometimes the soft tissue does regrow. I don't know what the rest of you think.
So I've heard a few, so again, there's some anecdotal tales, particularly for things like liposuction. I don't know if it disrupts the...
What we know is that the scarring is, in most patients, is frequently hypertrophic, keloids and hypertrophic scars. So that's why I tend to avoid surgery because of that problem.
But more because of the scars themselves
rather than the
excess rebound.
Exactly. Yeah.
On that note, Mansour, I needed to talk to you about this, but when I was at my appointment with Caroline Mills with Lily, I said, can we get, because we want to do some information on the website, on the RDCM website, can we do something on surgery to answer that exact question? Because this is something that gets massively discussed in patient forums where everyone's terrified. They're like, you can't operate because it's just going to come back worse, and that's a real sense of kind of anxiety. So I think if the answer is yes or no, someone needs to kind of put their heads together. The surgeons and the paediatricians and doctors need to put their heads together and kind of give us an answer, I think.
So I think there's different reasons to do surgery. So one is debulking, but I think what we see more often in children, surgery to increase function. So often you're not taking away a lot of tissue, but you're actually manipulating the hand round, slimming down the hand, slimming down the foot by removing a metatarsal. Yeah. You're putting a pin in the longer leg 2 years before your plate closes, your legs level out again. So lots of the surgical interventions we do, we're not massive debulking, it's not to get rid of loads of bulk, but it's actually to improve your function in lots of subtle ways, like tension releases, things like that. So that surgery is always a valuable adjunct, and even with the best medicines in the world, I think it always will be. I think when people think surgery, they may just think, oh, it's just cutting out all the bits that are overgrown. So again, that has, for particular reasons that may have, if you want a foot to be slimmer, so it fits in a shoe, for focal areas, that's often good. So we still do a lot of surgery. Do you do surgery in France as much? Do you have as much surgery in France? I think in paediatrics anyway, we do a lot of surgery. I don't know if the utility is the same in adults.
You mean we do more surgery than in the UK, or more than we did?
Do you think you? So I think we still work with the surgeons a lot.
Yes, we do.
Yeah.
So do we. Yeah.
So it's not. Yeah.
Yeah.
Does this also apply to the face? Young patients with facial involvement, do you also operate on that?
Yeah. So we work with different groups of surgeons, but max waxing, craniofacial, we normally have with faces.
My daughter had the bulking surgery when she was 3 days old. That was 25 years ago.
Quite a big surgery.
And
I was lucky enough not to go back.
She was £8.11 when she was born, £8 after the surgery, so it was quite significant. And she's just seeing, especially now, about having this GoPI therapy because there's some slight regrowth, but she's now 25, so it's quite a significant time frame. And I don't think it was ever really an option not to have surgery at that time. I think it was very little known, and so the surgeon was quite bold. He used bold rather than any other word. And she went in and operated, and it was successful. But pain management is an issue still. But yeah, so I always worry when everyone says, can't have surgery, can't have surgery. We may have been the only one it worked for, but it worked, and it's not an outright no.
It's definitely been worked for it. I think some of the plastic surgeons that we met at the Pros Day, they were keen to do a bit as part of a bigger, everybody discussing what their role might be.
Yeah, I think it's just about, even if the answer is we don't know, I think it's just about putting that out there for really, really helpful.
I think the answer will be that there's a role for it in certain
In
situations.
different,
and
yeah,
it depends
exactly,
on-
because I
yeah.
think we're both thinking of the face from our children and, you know,
Yeah.
it's stress. Yeah.
Unfortunately, we'll have to stop it there because Pierre's got to go, but thank you. Thank you very much.